Hey, future doctors. Ready for a deep dive into some seriously high-yield respiratory stuff? Perfect for those study breaks between the library and the wards.
We're talking about those tricky lung conditions, how to recognize them, and why they matter. Let's make those medical school lectures stick.
First up, let's tackle a condition that always seems to pop up. Atelectasis. Or, as I like to think of it, the, lung collapse. You with me?
I like it. And while it sounds scary, atelectasis is totally manageable, especially when you break it down into the three main types. Each has its own cause and treatment, so recognizing the difference is key.
Okay, 3 types. Hit me with it. What makes each one unique?
Picture this. Obstructive or resorption atelectasis. Imagine something's blocking the airway, like you inhaled a popcorn kernel, or maybe there's a mucus plug. The air in that part of the lung gets absorbed into the bloodstream and boom, collapse.
Makes sense. But get this, our notes mention something about the mediastinum shifting. What's up with that?
You're talking about mediastinal shift. It's a classic sign and super important for diagnosis. So, with obstructive atelectasis, the air pressure in the affected lung drops, right? The mediastinum, which is usually chilling right in the middle, gets pulled towards that lower pressure, like a magnet.
So it's basically a pressure game. The mediastinum just follows the path of least resistance.
Exactly. Now let's compare that to compression atelectasis. This time, imagine something pressing on the lung from outside, like fluid in the chest cavity or even air that somehow leaked into the wrong spot. It's like giving your lung a bear hug can't expand properly.
Oh, ouch. So in this case, the mediastinum makes a run for it in the opposite direction.
You got it. It shifts away from the atelectasis because the collapsed lung is taking up less space.
Okay, that makes sense. It's like a seesaw in there. One side goes down, the other side goes up. So what's our final act of lung collapse? What's the third type?
That would be contraction atelectasis. This one's all about restriction. Imagine your lung is a balloon that's lost its elasticity. It just can't fully inflate. This often happens because of scar tissue, which can form after inflammation or injury.
So no dramatic mediastinal shifts in this case.
Nope. It's all about that restricted lung tissue. And that's atelectasis in a nutshell. 3 different ways a lung can collapse, each with its own telltale signs on an X-ray.
Talk about high yield. All right, we've tackled lung collapse, but let's talk about something even scarier. ALI and ARDS. Those acronyms scream trouble.
They can be serious, for sure. Think of acute lung injury, or ALI, like your lungs calling in sick. They're inflamed, struggling to do their job, which is to get oxygen into your blood.
And ARDS is like called out completely.
Exactly. Acute respiratory distress syndrome, or ARDS, is the severe end of the spectrum. We're talking widespread damage to those delicate lung tissues. Often it's triggered by things like sepsis, severe trauma, or even a nasty bout of pneumonia.
Our notes mention something called hyaline membranes forming in ARDS. That sounds ominous. What exactly are we dealing with there?
Hyaline membranes. Those are like, imagine saran wrap, but over the tiny air sacs in your lungs. The alveoli makes it super hard for oxygen to get through.
Yikes. Okay, so we're talking life-threatening situation here.
You bet. ARDS definitely needs aggressive treatment. Think ICU level. You gotta support those lungs, give them time to recover.
Intense. Okay, so ALI and ARDS, definitely got to know those. Now let's switch gears a bit. Our notes talk about obstructive versus restrictive lung diseases. They're grouped together, but they're pretty different.
Totally different. Like think apples and oranges, both fruits, both good, but not the same. And knowing the difference, huge for figuring out treatment and all that.
For sure. Our notes use this milkshake analogy, and I'm kind of obsessed with it. Can we talk about that?
Milkshakes. Let's do it. So first up, obstructive lung diseases. Think COPD, asthma. Imagine you're trying to drink a milkshake, but your straw is super narrow. What happens?
You can get some in, but it's a workout, right? And exhaling. Forget about it.
Exactly. It's a struggle to get air out. That's obstructive diseases in a nutshell. Airways are narrowed, blocked, making it tough for air to flow, especially when you're exhaling.
So it's like the air gets trapped.
Yep. Now flip it around for restrictive diseases. This time you got a wide straw, no problem there, but there's only a tiny bit of milkshake left.
Ooh, I see where you're going. You can breathe, but those deep breaths, not going to happen.
Bingo. With restrictive diseases, it's not about blockage. It's that your lungs can't expand the way they should, like trying to blow up a balloon that's already full.
Okay, love the analogy. Obstructive versus restrictive. Got it. Now, let's dive into COPD. Our notes went deep on this one.
Makes sense. COPD, or chronic obstructive pulmonary disease, it's a big deal. One of the leading causes of death, actually, and it's complicated.
Complicated how? Like a soap opera.
Haha, kind of. It's not just one thing. Think of it like an umbrella. COPD is the umbrella, and under it you've got chronic bronchitis and emphysema, often both of them.
The terrible two. Do they always show up together, or?
Often, yeah. Each one makes breathing tough, but in different ways. Chronic bronchitis. Imagine this constant tickle in your throat, but you can't quite clear it. Airways are irritated, inflamed, and there's way too much mucus. Think smoker's cough, but it's not always from smoking.
Right. Our notes mentioned pollution, dust, all that stuff can trigger it too.
For sure. Now, emphysema is sneaky. Imagine someone slowly but steadily damaging the structure of your lungs.
The structure. That sounds intense.
It is. Think of your lungs like a building, right? All these tiny air sacs where the oxygen exchange happens. Emphysema is like someone chipping away at the walls. Those air sacs, they lose their stretchiness, they break down. Getting oxygen in becomes harder and harder.
Wow. And it gets worse. Our notes mentioned different types of emphysema.
True. It's not one size fits all, which makes diagnosis tricky. There's centriacinar emphysema, common in smokers, mostly affects certain parts of the airways. Then there's panacinar emphysema, often linked to a genetic condition.
Wait, genetic, like you can be predisposed to this.
Yep. It's called alpha-1 antitrypsin deficiency. People with it, they're missing this protein that protects their lungs. They're at a way higher risk, and if they smoke, forget about it.
Double whammy. So with all these different types of emphysema, how do doctors even treat it?
That's why knowing the difference is so important. Treatment has to be tailored. Inhaled meds to open up airways, pulmonary rehab to strengthen those breathing muscles, sometimes even surgery. It all depends.
Early diagnosis must be crucial, especially for those with the genetic link.
Absolutely. Catching it early can make a huge difference in how fast it progresses, how the patient feels. Quality of life is so important.
Couldn't agree more. Speaking of different respiratory conditions, let's talk about one that affects millions. Asthma.
Asthma. Interesting one, right? It's super common, but the how and why of it is pretty complex.
So asthma is like your airways are the drama queen of the respiratory system, always overreacting.
Pretty much. The key with asthma is this: hyperresponsiveness. Those airways, they're on high alert, ready to freak out at the drop of a hat.
Okay, so what kind of things set them off? I mean, what's on the asthma trigger list?
Oh, it could be anything. Pollen, dust mites, mold, pet dander, even exercise or that blast of cold air when you step outside.
And when those triggers hit, what's happening in the lungs?
It's like a mini freak out in there. The airways constrict, almost like they're trying to squeeze something out. That's what causes that classic wheezing sound you hear with asthma, that whee. It's air struggling to get through.
So it's all about managing those triggers, right?
Mm-hmm.
Avoid the freak out at all costs.
Exactly. Know your triggers, avoid them like the plague. That's step one for sure.
Solid advice. Now, our notes also talk about this thing called bronchiectasis. Bit of a mouthful. What's the deal with that one?
Okay, imagine this. Your airways, they're like the branches of a tree, right? Bronchiectasis is like those branches get all damaged, widened out permanently.
So instead of nice, smooth tubes for air to flow, they're more like, I don't know, warped straws.
Yeah.
All sorts of weird nooks and crannies.
Perfect analogy. And those messed up areas, they're like welcome mats for bacteria. Infections. Way more likely.
Ugh, that sounds awful. And is it just wear and tear that causes those airway branches to get damaged?
Not exactly. Could be a bunch of things. Sometimes it's genetic, like with cystic fibrosis. Other times it's chronic infections, immune problems, even blockages in the airways.
So many potential culprits. It really shows how everything in the respiratory system is connected. One thing goes wrong, it's a domino effect.
For sure. Big picture stuff. And speaking of big picture, we also got to talk about interstitial lung diseases.
Oh yeah, those were in the notes too. They sound kind of mysterious.
They can be tricky. Imagine your lungs are like this delicate fabric, like lace. Interstitial lung diseases, it's like someone spilled glue all over that fabric. It gets stiff, scarred.
So instead of being nice and stretchy, the lungs can't expand properly.
You got it. Breathing becomes so much harder. Imagine trying to breathe through like one of those tiny coffee stirrers.
Not ideal.
Yeah.
Our notes specifically mention IPF and pneumoconioses. What are those all about?
Right. So IPF, idiopathic pulmonary fibrosis, it's like the unsolved mystery of lung diseases. We don't know what causes it. Makes it super hard to treat.
So the lungs are just
Yeah.
getting all fibrosed.
Yeah.
And we have no idea why.
Pretty much. Now, pneumoconioses, those are a bit different. They come from breathing in certain dusts, coal dust, silica, asbestos, bad news.
Yeah, those don't sound lung friendly at all.
Definitely not. And each dust, it causes its own kind of damage. Like silicosis, it often shows up on x-rays as these round white spots. They call them eggshell calcifications.
Eggshell calcifications. Okay, that's definitely going to be burned into my brain now, thanks. So Pneumoconioses, those are work-related, right?
Totally. Miners, construction workers, anyone exposed to those nasty dusts is at risk. It's why workplace safety is so crucial. Good ventilation, protective gear, all that.
Absolutely.
Yeah.
Okay, we've covered some serious ground today. Lung collapses, genetic conditions, workplace hazards. Who knew the respiratory system was so dramatic?
Right. And we just scratched the surface.
So true. To all our listeners out there, keep those questions coming. This deep dive, it's just the beginning. Use it to fuel your own exploration of the amazing world of respiratory health. And until next time, keep those brains engaged and those lungs healthy.